Well, good morning, good afternoon, good evening, depending whereabouts in the world you are. And welcome to our workshop to introduce the reports that we've just produced on optimization in digital radiology. And I just say that this is out for public consultation now, but the public consultation stops on Friday, on the 28th of October. So after these workshops, we hope that you put in as many comments and helpful suggestions as you can. We decided to prepare this report on optimization, as we found when visiting countries around the world to advise on the sort of radiology and setting up DRLs, we've become aware that rather than just being a tool, the DRL has often become an end in itself. And we really want to focus now on achieving optimization. So that this has been particularly true in countries that have only recently started to get medical physicists in place. And so we've had concerns that in these early stages, in the first year or two, when medical physicists are being established, we're not getting enough interaction between the different groups, the radiologists, the radiographers, and the medical physicists, and they don't really understand each other's roles. And so we're doing this report, or preparing this report, to really try to improve communication and collaboration, because it can be difficult. Moreover, even if optimization does start to occur, it can easily grind to a halt. So we've prepared the report to emphasize the need for optimization and how it should become a part of everyday life. So I'll give my presentation in a minute. We're going to have, we're stopping in about an hour for a question and answer session. And then at the end of the whole proceedings, we'll stop again. So we would ask you, if you have questions, if you could put those into the Q&A box on the video. So I'll start to share my screen and look at my presentation. So we're trying to prepare a report to help you along the road to optimization. I'll talk about the principles of optimization, the process. I'll talk about collaboration between the professional groups, the methodologies, and also the organizational processes to try and make sure that things happen. I'll talk about the challenges of digital radiology, and I'll report on X-ray modalities, which will follow this one, and also the importance of training. So what are the core principles of optimization? Well, images should be of sufficient quality to ensure that an accurate and reliable diagnosis can be made and enable correct clinical decisions. So we're aiming at that, and the radiation dose is secondary, but the radiation dose used to achieve the images should have been adjusted to the minimum level required to provide an adequate image. So what are the risks in a radiological examination? There's many dose savings that can be made without affecting image quality, but we've got to remember the image quality, as that's the important point. So if we're lowering or reducing the radiation dose, we've got to bear in mind the effect it's going to have on the clinical image. And if we take it too low, then this will increase the clinical risk. So we're trying to get the minimum of the balance of overall risk. So that point where the green arrow is pointing. So there are challenges with digital radiology because the appearance of the image is adjusted to give an acceptable range of grade levels for optimal viewing. So the superficial appearance gives little indication of the exposure. but we need to ensure that patient dose and image quality are acceptable. So if you see all these images of chest x-rays, one on the left is underexposed, the one on the right overexposed, but for a superficial view, you don't see that. It's only when you look at the details. So we've got to overcome these difficulties. There's two levels of optimization. There's the design and construction of the equipment and the day-to-day working procedures that are followed by the staff involved. So regular review of every aspect of the imaging process is key to the successful achievement of optimization. So it'll only occur if all the staff are properly trained in their roles. Equipment operation is ensured through a comprehensive quality assurance program. There's ongoing monitoring, review, and analysis of performance, and everything feeds back to this continual development of protocols. So we're continually trying to make this just a part of everyday life. And so there's several components are needed in this. There's the professional skills and collaboration. So radiologists, radiographers or imaging technologists and medical physicists need to be working together and collaborating to achieve this. There's a methodology and technology, measurement of performance and evidence based on preparation of protocols and gradually improving this so these become closer to replicating the clinical tasks. And there's the organizational processes, documented arrangements for equipment testing and dose audit, and established links for the implementation and monitoring of optimization. But all of these things, they require facilities, training, they require time to develop the experience, and they require a structure and organization to keep everything together and make sure it happens. So we've produced this diagram of the components required to achieve optimization. So we start on the left with professionalism. So we've put the individuals performing their roles with the traditional organizational hierarchy, so separately, progressing to a multi-professional team approach. In the middle, we've got methodology, where we've got the basic dose performance testing, and then gradually moving to develop more expertise and tasks more related to the clinical imaging task. And then we've got the processes. So we might have things being performed in different places at random times, but not linking together and coordinating. So we want to develop harmonization and then systems across the whole organization. And we've divided these into different levels. The reason for this is because of these visits we've had to countries in Africa and various other places where aspiring to the higher levels of optimization is not possible. Certainly in the early stage, we need to define sort of a basic level of performance and basic optimization, which can then be built on through the intermediate stages to the advanced stage. So within each component, the levels of performance achieved will vary in different organizations and different countries. So the degree to which an organization has implemented optimization will depend on the equipment, the facilities, funding, personnel, the level of knowledge, and the experience available. So the report sets out broad categories within the different aspects of the system that would be in place to achieve the different levels of optimization. So the preliminary is just when the department or facility is being set up through basic, intermediate, and advanced. And we recommend that managers and staff of imaging facilities use the document to assess the level they've achieved and then to guide their decisions about the next step that they should take, how they should continue their actions in optimization, but use it as a sort of guide to what steps you need to take. So looking at these individual components separately. So for the radiological professionals at the basic stage, you've got radiologists, radiographers, and medical physicists performing their roles separately and independently of each other. The establishing of diagnostic reference levels is really involved in the move from level C to level B. So at the intermediate stage, we've got optimization teams comprising radiographers, radiologists, medical physics having been established. And we've got comparison of those survey results with the DRLs, followed then on by review and optimization of protocols. And then at the advanced level, we've got the whole optimization team involved in regular review of the clinical protocols, each feeding in from their own expertise. So just an example, the patient dose audit, the knowledge of doses is just the first step in the optimization process. But if you can involve, we should involve the personnel in performing these audits so that everyone has ownership or involvement in the process. So the multidisciplinary approach helps to ensure that then the value is apparent in the dose survey results, and then these are the operators who make the changes can appreciate what's involved. Then there's the methodology, the radiological evaluation of image quality. So X-ray performance testing and calibration initial surveys of patient, those are all carried out, but they don't link in together. At the intermediate level, we've got the patient dose audit, comparing results with evidence-based preparation of protocols and choice of exposure factors. And at the advanced level, we've got then analysis and evaluation of radiological images by a professional team. We've got improving protocols based on experience and comparison with benchmarks. And so with this measurement of image quality and development of protocols becomes an ongoing continual process. And then the processes. So at the basic level, we might have ad hoc arrangements for equipment testing and dose performance. We've got protocols based on local experience, and we've got limited documentation and procedures. But again, there's not the same level of interaction between all of these. At the intermediate level, we can then develop documented arrangements for testing. Perhaps we can start to develop a quality system for ensure that the periodic dose surveys and review of DRLs takes place. We have the evidence-based clinical protocols, which are under regular review. So we've got the results from these surveys and imaging performance feeding into these. And at the advanced level, we've got systems for establishing clinical protocols, performance testing, dose surveys applied across the whole organization and monitored through a quality system. So in that case, we've got the continual live review and optimization of imaging protocols. This is what we're aiming for, this continual process. So the requirements for optimization, we've got the team of multi-professionals, we've got the evaluation of equipment performance using parameters that are relevant to clinical use. And we've got evaluation and integration through an organization-wide processes, which ensure that the monitoring of performance and patient dose are carried out, and the results of monitoring are used in improving protocols and imaging performance. So we've got all these different components feeding into the optimization process. So going back to our diagram again, the DRLs, as I said, fit in really at this stage as we're moving from level C to level B. So we have a system for regular dose audit in the procedures. The patient dose audit results then compared with the DRLs and the equipment performance tests. And then the process require that the optimization team closes the audit loop. So they're acting on the results of the audit against DRLs by adjusting the examination parameters or protocols and taking account of the clinical imaging as well in this gradual development and improvement. Now, digital X-ray equipment is becoming ever more complex. So this is one of our problems. The features allow doses to reduce significantly without compromising image quality. That's great, but patient doses could be unnecessarily high if the settings are used with the settings used, but without staff being aware that anything is amiss. And we certainly found that in some of the situations where we've been carrying out training for the IAEA. So successful operation of digital X-ray equipment requires high levels of knowledge and skill from clinicians, radiographers, and medical physicists. Settings should be agreed by members of the multi-professional imaging team and documented in protocols. All members of the team must be given the necessary expertise through training and experience, and the training must be updated regularly so everyone fully understands equipment operation. So our task group report, Optimisation of Radiological Protection in Digital Radiology Techniques for Medical Imaging, is the first report, which, as I said earlier, is out for public consultation, but that finishes on Friday. The second report will deal with the different modalities, practical aspects in optimization of radiological protection and digital radiography, fluoroscopy, and CT. So we've finished that. It's going through the ICRP sort of checking stage, the final checking stage at the moment, and so should be out for public consultation either late 2022 or early 2023. So report one contains all these components. Dave will be talking about some of these later, but commissioning and user training on new equipment are a particularly important part in the early stages, and then regular review of protocols and optimization when the equipment is put into clinical use. The second part deals with all the different modalities, plus there are chapters on pediatric procedures and pregnant patients. So looking briefly, for digital radiography, we're establishing the appropriate KV and MAS values, calibrating the automatic exposure control devices, collimating the X-ray beam, monitoring the exposure index checking them against target values. For fluoroscopy, we'll be looking at the design features. Are they tailored to the clinical tasks? Exposure factor programs should be set up during commissioning with the application specialist. And then the QC program should evaluate performance of all the exposure modes and the selection of appropriate options. And then for multi-detector CT, appropriate selection of scanning parameters is the first thing. One might say you're using 100 kV with iodine contrast for small patients. Image reconstruction methods, use of image iterative reconstruction where appropriate, use of the automatic tube current modulation. And all these settings should be agreed by the radiology teams. And then the protocols developed with the tests and clinical performance and reviewed regularly by the team. So looking particularly at CT, so at level C, we've got our contrast protocol settings, the indication specific protocols. We might have the manual, we have to have our voltage selection and the scan mode and reconstruction settings. As we move to level B, we might then fully implement automatic tube current modulation, bolus triggering, perhaps post-processing or ECG gating. And then as we move to level A, it might be that we introduce automatic tube voltage selection, organ dose modulation, things like that. So there's different things which will probably be implemented at different stages because of the level of training and expertise as the staff gradually become more experienced. So what's the requirements to achieve optimization? It depends on the equipment itself and the people with the knowledge and experience to make proper use of the equipment. So failure to adjust imaging protocols to patient size or to the clinical question can result in unnecessarily high or low doses or poor image quality. There's two important aspects are the proper training of operators, that staff understand and are familiar with new technology, and that staff are able to fine-tune the equipment settings to achieve better results. And Kimberly will be going to that in more detail tomorrow. And then there's the ongoing monitoring, review, and analysis that ensures that the performance is gradually improved. So the message to take forward: consider the different aspects involved in the optimization process and needing to be improved in your facility. So have you got the necessary level of teamwork? Are all your methods for testing equipment performance and dose audit, are all they well established? And do you have a sort of harmonization of processes across the organization? Do we have a quality system monitoring things that triggers actions to be taken? So the radiologists, radiographers, and medical physicists, that's our reinforcing message. I know it's put forward by lots of other organizations, but we really want to emphasize this because we've found it is needed in many places. So they should work together as a team. Each should feed in results from their practice and measurements to continually develop, improve, and optimize protocols. Patient dose audit is an essential tool, but so are checks and image quality. So do not reduce dose to a level that affects the diagnostic quality of the image, and make optimization of protocols a continual part of the imaging process. So it just happens naturally within the imaging department. So I'd like to acknowledge the contributions from the other members of the task group, some of whom will be talking today or tomorrow, and others just pass on my thanks to. So thank you for your attention. So I will stop sharing my screen, and I will hand on to David Sutton, who's the secretary of our committee and professor of medical physics at Dundee, at the University of Dundee and Ninewells Hospital, recently retired. Thank you, David.
Thank you very much, Colin. And hello, everybody. I'd like to continue the discussion of the report by looking a little more closely at two of the areas that it considers, specifically in the context of optimization. I've been asked to start my video. Apologies. So the equipment life cycle and the analysis of patient doses. So we're all aware that while optimization is hard to pin down, it's key to effective and relevant radiation protection in diagnostic radiology. And as pointed out by Colin, two interlinked factors or pillars that contribute to successful optimization are the equipment itself and its operation. And as you saw in Colin's overview, optimization is most likely to be successful if radiologists, radiographers, and medical physicists work together rather than independently, if all staff are properly trained in their roles, if equipment operation is assured through a comprehensive QA program, and provided as well that there is ongoing monitoring, review, and analysis of performance that feeds back into the continual development of protocols. That's really our tenet, and all of these points are especially relevant in terms of the equipment life cycle and patient dosimetry. The optimization process should actually begin when you start to think about a new use of X-rays, whether it's a replacement piece of equipment or a new radiology department. It's a continuous process and is bound up with the detail of the imaging equipment life cycle. And the equipment life cycle, which is shown here, is a well understood concept and is used to describe medical equipment, including imaging equipment, from cradle to grave. Each element of the life cycle contributes to successful optimization. The stages in the life cycle are all important and include justification, acquisition or procurement, installation, acceptance, commissioning, user training, clinical use, and eventual disposal. Professional skills, methodology, and process all play a vital role in the management of the equipment cycle. Understanding and managing it appropriately is essential if optimization is going to be successful. As Collins pointed out, QA of the whole system helps ensure that this is achieved by focusing attention on the many different aspects of performance that need to be maintained. In part one, we discuss each aspect of the life cycle, and I'll briefly touch on the major considerations discussed. In retrospect, they're probably self-evident, but nevertheless, they're very important. So the first stage is justification. The procurement of all medical imaging needs to be justified both in terms of clinical need and radiation dose. Justification should be evidence-driven and take into account present and future clinical applications. If the proposed use of the equipment isn't justifiable, then the foundation for any consequent optimization is shaky, I would say, to say the least. So it's a very important step. The next stage is acquisition, or what you might call procurement, which itself has several components, as you can see from the diagram. It's essential that the procurement team think about the performance specification of the entire system before buying anything. They need to know what the intended use is, how it's going to be used operationally, and what the requirements are in terms of dose and image quality. And the supplier, in turn, should be able to demonstrate that what they're offering meets the specified needs. And of course, all this needs to be documented. So once a contract has been placed, one moves on to the enabling and installation process. Planning and construction of the X-ray room, its radiation protection, and the provision of electrical and other services all need to be thought about beforehand. And as well as that, consideration should be given to the appropriate movement of the patient and positioning of the attending staff if doses are going to end up being optimized. The result should be detailed plans that can be then physically realized, which can then be used to inform the installation process, both of infrastructure and the equipment itself. And once the equipment's been installed, the next step is acceptance and commissioning. There is a lot that can be said and a lot has been said about both of these topics, but it's key that the team understand the difference between acceptance and commissioning. You need to satisfy yourself that the manufacturer or supplier has supplied what you ordered and that it meets the specification. This is called acceptance. You also need to establish baseline values that you will use for subsequent comparative testing, whether it be on a daily, weekly, monthly, or yearly basis. And this is commissioning. It's important that your plans allow sufficient time for both, and also for the resolution, of course, of any issues identified, especially during the acceptance phase. And before the user can be used, as Collins pointed out, users need to be trained. Pretty obvious. User training is obviously of paramount importance, and a chapter of the report is devoted to it. But some of the main points discussed are: user training is critical for safe, optimized use of any imaging equipment. Initial user training should ideally be provided by representatives or the representative of the installer and the manufacturer following acceptance, and before the equipment itself is put into clinical use. And also, it's quite likely that not all end users of the equipment will be able to receive the initial training, since it should also be given to anyone who's required to use it after it's put in. Consequently, there need to be arrangements in place to ensure that training can be delivered by an agreed cascade process. And Kimberly is going to discuss this in more detail, as Colin has said, tomorrow. And then, of course, the period in which the equipment is actually in clinical use, which is shown here in the inner circle. And that's probably the longest phase of the life cycle. And it's worth remembering that everything shown here, including safety issues, including maintenance, upgrades and refresher training, and quality control, are all important contributors to the success of the optimization program. Possibly just as much, in fact, as regular review of the protocols that are going to take into account dose and image performance, which we've called optimization in this diagram, but we do plan to change it. And finally is the end of life of the equipment. Well, what exactly is the useful life of the equipment? How do you decide that it should be replaced? Even if you think it should be replaced, is replacement justifiable? And then with that justification, you begin the life cycle again. And how will you dispose of it? Or is there another potential use for it? All of these issues are discussed in the report and are key, really, to optimized use of the X-ray equipment. So moving on to patient dose. As Colin said, patient dose and its measurement and subsequent analysis is of central importance when it comes to optimization. It's an integral part of much of the equipment lifecycle. We specify dose, we accept against the specification, we use dose as the basis for commissioning, management of dose is part of user training, and we measure dose in QC and use it in dose audit during the clinical phase of the life cycle. A core principle is that patient dose should be adjusted to the minimum level required to provide an adequate image. So it's important not to lose sight of the fact, as Colin's already said, that the dose we want is a dose required to achieve a desired image quality, and that image quality is both task and reader dependent. That is, the choice of factors that influence both patient dose and image quality depend on the patient, the clinical question, the examination, the operator performing the procedure, the equipment used to image the patient, and of course the person interpreting the eventual image. So given that caveat, the report discusses several aspects relevant to patient dosimetry, and I've listed them here, and I'm not really going to go into them. They are the influence of exposure factors on radiological images, surveys and audit of patient dose data, measurement and retrieval of patient dose data, analysis and feedback of patient dose data, the outcome of the dose audit process, and the use of patient radiation exposure monitoring and management systems in the context of dose audit and optimization. To provide just one simple example, this table, which is reproduced from the report, shows some of the factors that affect patient dose and also their impact on image quality. So, for example, increasing field size will result in an increase in cap, has no real impact on entrance surface air cover, but degrades the image because of the increase in scatter. Of course, this is all well known and can be further studied in a wide range of radiological textbooks, but it's a pointer. So again, knowledge of doses delivered to patients by imaging procedures is the first step in the optimization process. And this knowledge can only be gained by surveys of doses to real patients because of the nature of the distribution of doses. Patient dose surveys are essential in the development and implementation of an organization's dose management strategy. Just to remind you, patient dose audit is the process whereby the results of a patient dose survey are compared against relevant standards, and the most relevant current standard is the DRL. However, patient dose audit against DRLs, or indeed other standards, will only contribute to optimization if action is taken to address dose levels that are high, or indeed any other issues that are identified. The flow diagram in the slide is reproduced from ICRP publication 135 and shows the patient dose audit cycle, which is familiar to everybody. I'd personally like to point out that the basis for comparison here that you see, the flow diagram, should take into account the uncertainty budget or combined error associated with the physical measurements recorded during the survey. This is a simple point, but it's often overlooked. So two of the key messages in the report are that personnel involved in performing the exam should have ownership and involvement in the process of dose audit, and a multidisciplinary team approach helps to ensure that results of dose surveys are fed back to operators who will make changes that might be needed. And another key message is that DRLs are not the end point on the road to optimization. They are merely one of the first steps in terms of patient dosimetry. They act as a guide to the indistinct border between good and normal practice and bad and abnormal practice. And because of the way they're defined, which is usually around the 75th percentile of an aggregate of samples taken from a population of images that are deemed themselves to be diagnostic, they are based on the observation that if most radiologists agree that a particular dose produces an image that is diagnostic, then it probably is diagnostic. So they're really at the top end of trying to balance patient dose and image quality. Nevertheless, patient dose is an essential tool, but so are checks and image quality and lots of other things too. I suppose one important take home is do not reduce doses to a level that affects the diagnostic quality of images, which can be quite difficult to do in digital imaging. And Mika is going to explore the whole concept of image quality in the next talk. So The report shows how patient dosimetry can be included in what you might call the hierarchy of optimization, as described by Colin. This very busy slide, I'm sorry for that, shows table 4.2 of part 1 of the report and provides an indication of the arrangements that you might expect to be in place at different levels of optimization. So these range from, for example, at the top, the availability of radiation instruments for measurement of radiation dose and exposure parameters at the basic or pre-optimization infrastructure level. 2, the application of dose management system software at what you might call the advanced level. And the next 2 slides just build on what Colin showed you already. Simple examples of the different levels of optimization in terms of what I call the optimization hierarchy. At level C, which is shown here, level C, which is shown here, an institution may have ad hoc arrangements for equipment testing and dose audit. Staff may be carrying out dose surveys and also performing some equipment testing. An image might be assessed using anecdotal clinical evidence. But essentially, radiologists, radiographers, and medical physicists perform roles separately and most likely independent of each other. And this is what we would call level C, basic level of optimization. And as Colin's already pointed out, the transition from level C is aided by the establishment of DRLs and the adoption of patient dose audit. So just to include that in this case, we've moved to the point where we now have documented arrangements for testing and dose audit. Patient dose audits are compared with DRLs, and evidence-based clinical protocols are under regular review and refinement by a team of professionals. And obviously, these are just basic examples, and you need to mix the whole thing in together. But I hope they demonstrate the point of how dose audit and patient dosimetry fits into optimization. And finally, just a very quick word on quality and quality management and its role in optimization. So if, as we are proposing, professionalism, methodology, and process are going to be harnessed in such a way that optimization is successful, there needs to be an underpinning framework that facilitates the systematic approach to achieving that goal, i.e. a quality framework. In the report, and I'm not going to go into it, but in the report we discussed the components of a radiology quality system and the elements that may constitute aspects of quality control, quality assurance, and quality management. And the hierarchy and stages of optimization is to some extent, I think anyway, reflected in this progression from QC to system-wide QM. 15 minutes and 31 seconds. Thank you very much for listening, and I do hope you enjoy the rest of the program.
Thank you, David. So Dina is the head of radiology and radiation protection at the Department of the Egyptian Atomic Energy Agency. So she's an interventional radiologist. And so she and Kimberly have been putting in the sort of clinical input into our report. So she's going to talk about the roles, responsibilities, and the team approach, which she's very keen on.
Good morning, colleagues. Good morning, ladies and gentlemen. It's my pleasure to present the role, responsibilities, and the team approach in the ICRP new publication towards optimization. I'm Dina Husseini Salama, Professor of Radiology and the Director of Medical Imaging Program in Egypt, and I'm the Chairperson of AFRA Project Management Committee. In the new publication, ICRP is not focusing only on equipment, but we are focusing on people, on their responsibilities, their knowledge, skills, and competencies. They are our important assets to improve the status of optimization worldwide. For better understanding of the concept of optimization and the team approach, we need to know that one of the great obstacles for optimization is proved to be the limited appreciation by different professionals of their respective roles and responsibilities. This actually creates a barrier to effective communication, which leads to delays in our procedures, protocol errors, sometimes repeated imaging, and patient safety concerns. The team members, all of them, should complement each other, should understand what's meant by a team culture of optimization. We need to improve our mutual understanding and become familiar with new technology needs. Actually, the optimization and team approach in the current status is the picture on the left side, which is a multidisciplinary empty room. Nothing to discuss about optimization and to sit together. We need to be in the picture in the right, sitting together, understanding each other, working with each other. So for building stronger teams to support optimization, the optimization should aim to improve patient care at first and optimize clinical outcome rather than focusing on ALARA and dose reduction alone, as we used to have this kind of practice. This is an iterative process and strongly related to quality improvement, as well as linking to the principles of biomedical ethics is very important in our process. Training on optimization should include means to improve professional knowledge, skills, attitudes, and develop competencies needed to effectively implement optimization with its full meaning. And the education and training section will be discussed tomorrow in details. This way, we can build stronger teams in the field of optimization. Working in a team will make physicians, radiographers, medical physicists, and nurses work together efficiently with better mindsets. This is what we need at the time, being in an innovative atmosphere, freely sharing their mistakes, showing themselves capable of positive criticism rather than improving the performance of the team and its results. And we need a core team, actually. This core team will be basically from medical physicists, radiologists, and radiation technologists. This disciplinary core team will improve mutual understanding and they can be responsible to build a team culture and promote effective communication in other team members, which I will discuss later. Regular reflective meetings on optimization, quality improvement, and review of lessons learned is essential from safety and near misses events that will support ongoing education and improvement of the current status. Again, it's imperative that an appropriate training regime is developed for this core group. This core group that we rely to implement and to engage others with. Imaging professionals must learn how they can work as a member of the core team to implement it across a growing variety of imaging modalities, complex protocols. Every day there is a new imaging modalities and new complex protocols which we need to address this issue and integrate it in the training programs. Different patient sizes, all this has to be engaged in our and known by our core team very well. They are important goals. These are important goals of the training for the core team professionals in optimization that should be considered when developing learning objectives. For improving teamwork skills in optimization, the staff should receive instruction on team building and communication with other disciplines. And also the trainers themselves should be role models for proper teamwork, and this can be facilitated by cascade training activities on optimization specifically tailored to multidisciplinary teams. This approach will support team culture and safety culture, and this is what we need at the time being. For building a teamwork atmosphere towards optimization, it can be specifically achieved by we need to share our activities, divide the responsibilities between the team members, allocating multiple tasks so that individuals can substitute each other whenever possible. We can easily relocate them, share rewards, and give accountability to their work, encourage positive competition between the team members. This is not existing in many radiology departments, and this is the real solution to if we want to implement real optimization. We want to share experience in a continuous manner. And now I want to go to the role and responsibilities of professionals involved in the process of optimization. The health professionals involved in the medical imaging should provide the knowledge, skills, and competencies needed for them to perform optimization effectively as part of their role. And we are emphasizing on this in details in the new publication because we found that many of these professionals are not aware what are the real role, their role and the responsibility towards optimization process. This is not constrained to only radiology and medical physicists as it is well known, but it applies to full range of professionals involved in medical imaging that I will speak about later. We need also to tailor our approach for technologically based roles like radiologists, medical physicists, technologists. We need to inform them about new protocols, softwares, imaging methods, and technologies. And but on the other hand, for those like anesthesiologists, management people, simple awareness of the issues can be enough. So we need to tailor our approach according to the needs. And regarding the role and responsibilities, I would like to start with the referring physicians because they need to precisely formulate in the request the clinical questions that needs to be answered in their request for the imaging procedures, and they have to know that it's their important responsibility while starting to work in any of the hospitals or the clinics. It should provide also all relevant documentation. They should provide also all relevant documentation and information that will support imaging specialists in selecting the best image acquisition approach, whether we are speaking on justification or optimization. And let me go now to the radiologist. Also, they from the very beginning, when they start their work, they should be involved in the decision-making process on the appropriateness of examination and in patient protocol development, selection, in interpreting imaging and reporting results. This is their main responsibility. But in addition, patient protection and optimization should be added clearly, and what they have to do, it will be mentioned in details in the new publication. So I invite you to read it. And also not only responsible on themselves, but they are responsible for the protection of all the staff members and patients, especially in the fluoroscopic procedures. Let me talk now about other physicians performing image-guided procedures like cardiologists, orthopedicians, neurosurgeons, gastroenterologists, and many others. They should take the responsibility for selecting also the optimal acquisition protocols, interpreting images, and reporting results. Together with, if there is a radiologist in place or they are taking over the whole examination, they should take the responsibility for patient protection, and they also play a role in the protection of staff members, assisting them in the procedure. This is not the case nowadays, and we need to define their role while starting working in their own facilities. Radiographers for imaging technologies, these are the real players and the operators of digital radiography, CT equipment, and etc. And they are the main persons interacting with the patients. So they are responsible for using the most appropriate acquisition protocols tailored to the patient's size and conditions that will provide a diagnostic content needed at the lowest possible dose. Effective interaction with the patient is very important in the process of optimization and play a key role in achieving best result and the best for patient care. They also perform the quality control measures and ensure consistency of performance is maintained in the whole program. Let me talk now about a very important profession, the medical physicist and their role in medical imaging. They have a key role in ensuring a link between the equipment, software, and its clinical use. And the ICRP strongly recommend that the access to medical physicists qualified professional in medical imaging is mandatory and should be ensured in all activities related to diagnostic and interventional radiology, because actually they understand better the needs for the many complex CT, digital radiography, fluoroscopy, and fluoroscopy guided procedures in modern imaging facilities. They can define, supervise the quality control, quality assurance program, which include patient dose monitoring, dose audits for comparison with DRLs. They need to be brought into optimization teams to work with the other professionals. What about other staff involved in preparing patients for performing procedures? I'm interested to mention now the forgotten staff. We need to bring them on the table and engage them in the process of optimization, like I've mentioned, the anesthesiologists, speech therapists, nurses, clerical staff, facility managers. Sorry. Equipment and software vendors, I will not discuss them in details. The role is written well in the new publication. And there are other kind of medical physicists and biomedical engineers who are involved in the development of technical specifications for purchasing imaging equipment. They should be involved in the team and with different roles and responsibilities. Now coming to the regulators, they have a very, very important role because they should have an understanding better understanding of doses, dose units, and both the potential benefits and radiation health risks with each imaging modality for proper radiation protection oversight. There is a lot of work has to be done still with the regulators. And at the end, again, we need not only to focus on equipment, but we need to focus on people, their responsibilities, their knowledge, skills, competencies. And at this point, I would like to thank you very much for your attention.
Well, thanks to Dina for that presentation. We're now going to go back to Mika. And we're going to run the slides. Charlotte from ICRP is going to run the slides for Mika by sharing screen. You want to share screen, Charlotte?
That's great. Thank you, Charlotte. Let's try again. So my topic was image quality and how to take account of that. And I was able to go to the first slides after this topic slides. So when we think about a successful optimization in radiology, the key point is to gather adequate information to secure diagnosis, inform care decisions, and guidance for interventions. And next one. So when we think about the definition of image quality, it's all about how effectively image can be used for its intended clinical task. So the adequate image quality is a fundamental requirement for any successful optimization. If we miss that, any kind of dose level, however low, is too much and wasted dose. Next one, please. So when we compare different modality and look at the digital radiology development, there are many factors affecting dose, radiation dose, and image quality. Here is an example of process circle of digital radiography from referral to report. And when we think about this from the quality or optimization point of view, all the steps must be optimal and secured in order to arrive to accurate and reliable diagnosis. So the first step from patient imaging geometry to imaging parameters mostly and directly impact the patient dose, the radiation exposure to the patient. But all of these steps are directly affecting to the clinical image quality. So the clinical value of these images is dependent on physical and technical characteristics, which are tightly involved in the role of medical physicists. Within the image capture and presentation system, also the workflow is important, and in the role of radiographer, and the final point, which is the radiologist review. So when we think about this circle, we absolutely have to emphasize the whole buildup of sufficient image quality in these intermediate steps. Next one, please. So the radiologist's role, please, one step behind. One important thing in optimization and in that process is the subjective image quality evaluation of a radiologist. And that is one of the core points of also the quality assurance program. And in the sufficient optimization model, we should secure that subjective evaluation against agreed good image quality criteria, which is given, for example, by professional radiological societies. The basic image quality is described by contrast, resolution, and noise to be in a very simple descriptor of image quality. Spatial resolution is first of those which I shortly review here, which refers to the level of detail that can be seen on an image. Resolution is a good example of image quality parameters which have a strong tradition in technical determination or measurement of resolution. Typically, this is done with high radiation dose and high contrast conditions so that we can acquire precise results. But then again, we have a whole different situation with clinical imaging of the patients, with typically lower clinical contrast levels, with lower radiation dose levels according to optimization. So we should be able to elevate our methodology for optimization and quality assurance to extend from this technical side more to the clinically oriented parameters so that we can be more effective for optimization and our image quality can really steer optimization. Next one, please. Another key parameter, obviously, is contrast, which refers to our ability to detect intensity or grayscale differences on a radiological image. It can be in an arbitrary units like in a post-processed digital radiography systems, or as in CT, calibrated contrast scale in Hounsfield units based on water attenuation. Nevertheless, the contrast resolution is also combined with the resolution to provide detectability of clinical targets. Next one, please. However, the contrast and resolution targets are interfered by noise, which is fluctuations of image intensity values around their mean value. So this interferes with contrast detectability and detail detectability. So we are talking about a distractor. If you put one, push more to the slide. This noise propagation is going through an imaging system, and mainly we are concerned about a quantum noise or statistical or random noise, but we can also have another noise sources within an imaging system, including structured noise. It can be correlated or non-correlated. Typically, we have non-correlated noise. Next one, please. The image noise is also heavily related to the radiation dose levels, especially when we describe this as a quantum noise, which follows roughly Poisson statistics. So if the dose level is doubled, the noise which we can observe in the image is decreased by 30%. This example slide also presents how you can utilize human-like anthropomorphic phantom models for optimization and image quality determination. So this example is from 5-year-old anthropomorphic model with noise simulation. And if you push forward the slide, we can see how the dose reduces and the noise increases according to Poisson statistics. At some point, you can see how we cannot see clearly anymore the smaller targets in the image and the lower contrast targets. So basically, we are trying to find the level which is limiting our adequate clinical image quality in this case. So we can utilize anthropomorphic phantom as an effective tool, as a one step towards clinical image quality measurement. Please, you can put the noise higher and you can see how it goes higher in the slide too. Please proceed. And again, here you can see how the noise propagates and increases a lot. So the noise is a distractor. And if we look for how it affects the visualization of targets with different sizes, contrasts, and noise levels. Actually, I'm seeing the previous slide. Thank you. In this image, there are 5 targets. You can hardly see all of them, but you might get a picture from maybe the 3 of the strongest targets. If you now push the slide forward, we can decrease the noise level, and you can see how you can discern better even the smallest targets in this image. So the noise is an obvious distractor together with the size of the target and the contrast scale. And now if we push the contrast higher and increase the noise to the original level, we can still see finally all the 5 targets despite of the high noise level. So there's an interplay with these different components of image quality. And already from this demonstration, it's clear that the clinical indication has a strong effect of what we are looking for and how we can optimize radiological modalities based on kilovoltage and dose levels. Please proceed. In the component model with different levels of optimization, which is already presented by David and Colin, there are some examples of image quality related metrics with these different levels. So on the pre-optimizing level D, where we have the basic infrastructure, I would just like to emphasize the importance of basic simple phantom availability for basic image quality assessments for all imaging modalities. Please, let's go on. On the next level C, which is the basic level, there are more wide range of methodologies in use, and I would like to emphasize the subjective clinical image quality evaluation paired with a patient dose audit, so we can get the both main pillars of optimization in our evaluation and quality control. Next one, please. On the B intermediate level, we will have more elaborate methodologies in use, including geometric phantoms with the shape of the patient, so we can test image quality, which is closer to the clinical situation. These are short, small images from the anthropomorphic head phantom. Please, let's go on. And in the advanced level, we have much more versatile methods, including more complex anthropomorphic phantoms for both dosimetry and image quality assessment. Also paired with a systematic and wide-scale monitoring systems and optional methods such as model observers and more recently artificial intelligence or deep learning based methods in our use. So we have much more abilities to go towards more evolved clinically relevant image quality parameters and metrics. Please, let's go on. So when we come back to basic definitions of image quality, we should be able to measure how effectively image can be used for its intended diagnostic task. And while we try to quantify that in objective methods, we should be more specific, like what's the ability of an observer to detect a targeted lesion. Next one, please. So we evolve our image quality parameters towards more advanced level, from basic physical image quality with technical phantoms to take into account the clinical factors and arrive to detectability, which is resembling in an objective way the way radiologists are trying to look for specific targets. Next one, please. So what we are trying to do in image quality aspects of optimization, in the future, we are trying to build bridge from technical to clinical side. Next one, please. So we evolve from technical phantoms to more clinically oriented data, whether from the patient or computational models or anthropomorphic phantom physical models. Next one, please. It's all about clinical image quality and how to find the right level for that. We can always boost technical image quality, but what is important is the vertical axis. What is the clinical value of our imaging operations? Next one, please. So if we are in very low end or high end, we don't have any additional or relevant information built. So we should avoid these extremes and concentrate on the specific indication why the imaging exam is done for this specific patient. Like, please, forward. For example, head CT scans. Sometimes we need higher technical image quality to create clinical value. But then again, for ventricle size evaluation, we do just fine with noisier images. Next one, please. And again. So we need indication on patient-specific optimization. And that is one of our key messages and key targets in this higher levels of hierarchy of this optimization strategy we are building. Next one, please. So with this, I would like to acknowledge the contributions from the members of the task group. It's been a very good collaboration between us. And I thank you for your attention, and I'm sorry for the interference. Thank you.
Well, thank you, Mika. I think that sets out some of the issues and the things that we need to take forward, looking at image quality in much more detail in the future. Kimberly, have you been looking at the Q&A? Or
yes, there are a number of excellent, interesting questions. And we can just go sort of in chronologic order here and start with Alan Calvert submitted a question, which is looking at the definition of optimization. Some of it, I think, was just answered by Mika in terms of his comment about how we define optimization. But perhaps, Alan, you want to elaborate further. I tried to answer it in writing, but I think that he elaborated more on Colin's second slide. I think Mika went into more detail about how we look at image quality, and I think that answered it a little bit better. So Alan, I don't know if you want to comment or to say something more. It's complex, and it depends on your level. It's hard to put one answer to what our definition is. If you ask all of us, almost 400 of us, we're going to have different definitions. So we were careful in the document to provide different levels depending on your resources and your training. I don't know if Alan wanted to talk.
I think he can.
He can't talk, I don't think.
Oh, okay, he can't. So David.
I could just say, Alice, I think Alan's question was, just in case everyone hasn't seen it, the key to optimization is specification. What do you want to see in the image? My favorite radiographer used to say, I don't do chests. Tell me what you think is the problem and I'll give you the best diagnostic image of it. Well, is that not just around the fact that what I said and what Mika said and Colin alluded to, that it's the whole question is task and reader dependent. So it's, you know, it's a really difficult question to answer, but
Well, what
I don't think
makes-
the key to optimization isn't specification. It's just that optimization is trying to get the best result, but everyone's looking at it differently.
Well, but Mika's slide 17 said we need to know what we're trying to image. It's not just the body part and making sure we collimate and learn all the things that we need to
Yeah,
know,
sure,
but
but
it's
I mean,
also the clinical indication.
It's the
right?
task. That's
Right.
what I mean
So
by
slide
task.
17 kind of answered that. But it's
So-
also, you know, we don't just do DRLs. We don't stop with them. That's a starting point. And yes, particularly in interventional procedures, we need to know, you know, what we're trying to do. And if it's more complex, or if the patient's body is not your typical body, it is complex. And we go through that more in part 2 of our document, which will be coming out a little bit later. So
Yeah,
I
'cause
hope
we feel that it's something that there's been the potential to address ever since digital radiology came on the scene, but we've not really taken that step as far as we ought to, and now is the time that we need to do that.
Yeah, and one other comment I'll make is that retrospective analysis of data is still part of optimization. I mean, how else do we get DRLs? We do a survey. I still think that we learn from, you know, mistakes or near misses. How else are we going to improve? We have to know that we're following our policies and our procedures, and then use it in a learning culture to say, oh, we need to do this maybe a little differently. So I will, you know,
I think we need to move on. We can perhaps take one more question, and then
can we look at Jim Weston, who just had a question for David Sutton. Did you see that, David? It was about quality statements and the equipment life cycle. But if we can also come back to this.
I've seen one which is about making reference to DRLs when setting and witnessing the requirements for acceptance testing. Is that the question?
Yes, yes.
Okay, well, so for acceptance test, I'm not quite sure what Jim actually means. So the acceptance testing in your specification, you specify what the machine should do. The manufacturer tells you what it'll do, and you accept the manufacturer's specification. You see whether you see whether or not the manufacturer has supplied equipment that meets the specification. So given that DRLs are movable and can continually change, I'm not quite sure what the question means. I mean, the specification should say what doses should be, but in general, specifications aren't task specific. They would say that the dose rate at a particular kV and MA should be such and such, or the dose rate through a particular phantom should be such and such. I don't think that DRLs really should be part of the specification, other than a generic statement that says something like the equipment should be able to comply with modern dose and image quality standards. But they're all specified in the specification, which is why the procurement part of the life cycle is so fundamentally important. You need to get that right.
Yep. Okay.
okay, I think we'll pass on, and now we start to go through the comments that we've had from the international societies. And so Charlotte, John Damalakis, who is president of the International Organization for Medical Physics, has given a sort of feedback on, he says it's a personal view rather than that of the society. So if we could go to that, please.
Dear colleagues, first I'd like to thank ICRP and Dr. Colin Martin for giving me the opportunity to present my views as IOMP President on the ICRP Task Group 108 report. Medical imaging research and technology is evolving rapidly. In recent years, manufacturers have introduced very advanced but highly complex radiographic, fluoroscopic, and compute tomography systems. The optimization process is vital for the radiological protection of patients and especially for patient groups such as neonates and children, pregnant patients, and patients that need multiple exams due to specific clinical conditions. However, this process is neither straightforward nor simple. Dose reduction and optimization cannot be achieved by following simple steps or by simply altering technical parameters to reduce patient dose. The complexity of the equipment, the pace of technology evolution, the number of parameters involved make the process quite demanding. There was a need of a publication on optimization of radiological protection, considering all steps of the imaging procedure, the selection and installation of equipment, design and construction of installation facilities, acquisition protocols, the methods and modes of operation. Additional requirements for taking the optimization process forward include the need for quality control programs, the development of high-quality education and training programs, and the need for collaboration between referring physicians, radiologists, interventionalists, medical physicists, radiographers. The work of Task Group 108 focuses on optimization of radiological protection in digital radiology techniques, taking into consideration all relevant aspects and parameters. Task Group 108 reports provide information needed to move from conventional optimization to indication-based, patient-specific, equipment-specific, and protocol-specific optimization. They cover theoretical and practical aspects, enabling X-ray imaging departments to develop optimization strategies that are appropriate for their own equipment, for their own needs. And I'm really happy that this work also touches on an important issue, the shortage of radiology physicists in many countries. Optimization of radiological protection without full engagement of clinically qualified radiology physicists is not possible. Having said that, I would like to wish you all a stimulating workshop, and I look forward to working with all of you. Thank you.
Well, thank you, John. He said he may be able to join in, so he may or may not be listening, but thank you, John, for your input. Now we move on to Guy Frieger, who's co-chair of the International Society of Radiology Quality and Safety Group and also chair of Eurosafe Imaging. Guy is well known around the radiology field, and please start sharing, Guy.
So thank you, Martin, and thank you to the ICRP for giving us the opportunity to, I would say, to give our feedback on your last digital workshop on optimization of radiological protection in the digital radiology technique medical imaging draft. And before to give our feedback, I would like just to remind how to proceed to the next slide. Okay, good. So just to remind that what I will be presenting today is not a personal opinion, it's the feedback of campaigns around the world. You have here the campaigns who responded to our request to give a feedback to your draft. And as you can see here, there are several campaigns from Asia, the Asia Safe, campaigns from Japan, from the Arab area, from Europe through Eurosafe, AfroSafe, Latin Safe, Canadian Safe, and also Image Gently and Image Wisely. So what I will be presenting today reflects the, I would say, the opinion of this, the consolidated opinion of this campaign. Could you go to the next, please, Charlotte? Okay, I just have one slide because I think we could concentrate what we want to say into one slide. Of course, it is important to consider digital radiology. We think that is a very important topic, and I think ICRP was right to address it. And below have some points which were stressed by all the ISR QSC members. The first thing is that maybe we would need a clear definition of digital radiology, because in some areas digital radiology could be confused with a plain X-ray radiography, and I think that a definition would be welcome. Secondly, I think making a clear distinction between techniques from the beginning would be helpful, because the challenges for plain X-rays, CT, and fluoroscopy guided interventions are completely different. I think each technique has its own challenges. Third point, it would be interesting, in order to be more concrete, to provide some example of good practices, and probably this is not clearly mentioned in this report, and to think also of implementation of good practices. What is the strategy of implementation, rather than just describing the theoretical aspect of, I would say, failure of good practices. To think of key performance indicators in diagnostic radiology, for example, retake in plain X-rays, but they could be extended to other modalities. To think more often to local clinical aspect of optimization, and for example in CT to local clinical DRS. This was exemplified during the Euclid project. To think of the role of dose management systems, which is, in the opinion of these campaigns, not enough stressed. And finally, maybe to do not exaggerate the risks, because there is an umbrella of a risk from the beginning, and we are convinced that this umbrella of risk corresponds really to the clinical application of ionizing radiation. So we have one other suggestion, maybe to consider other experience, like in Europe, for example, and corresponding reference were provided to the report. And there are comments along the report which were provided, and we sent you to Colin. And more briefly, we would be happy to simplify the text and avoid too many digressions on one hand. And more generally speaking, we would prefer a short report, which would be complicated with annexes. But thank you. I think that's it, and that is a good summary of the feedback of these campaigns around the world. Thank you again for the invitation. Over.
Thank you very much, Guy. We will go through all your comments and mull them over. I think some of the sort of modality issues that you raise will be addressed in our second report, but we can discuss that later on. For now, I will introduce Stuart Whitley, who's the Director of Professional Practice of the International Society of Radiographers and Radiation Technologists. And I think Charlotte has the recording of Stuart's talk.
Good morning, afternoon or evening. My name is Stuart Whitley, the ISRT's Director of Professional Practice, and it's good to be here today. And I thank the organisers for the opportunity to feedback what our members have said in response to the draft document. The ISRT represents over 80 member societies with a total of approximately 500,000 radiographers and radiological technologists, and we're greatly involved in educational matters through our website resources, our workshops and position statements. Radiographers do take an active part in the optimization process at all stages, including good radiographic technique, involvement in QA/QC, and in directing and educating its users. I'm just going to use 2 more slides. ISRT is pleased to comment and provide feedback for this excellent draft document, which is a valuable resource containing a lot of useful and well-written content. And we particularly like part in education and need for CPT. In terms of a teamwork approach, we are particularly pleased and support and welcome the concept of a team approach, as radiologists, medical physicists, and radiographical technologists working together have a lot of shared knowledge and experience in dose optimization. We have provided several comments and suggestions for changes and updates, and of course these can be found on the ICRP website. We need to recognize that roles in certain countries differ. We need to recognize that the contractual arrangements for medical physics support do differ. We can either have in-house or bought-in services. And of course, in certain situations, physicists are not always present. So good communication and teamwork is necessary. Also, we should note that in Japan, medical physicists are rarely active in the diagnostic field, and therefore it should be clearly stated that radiographers, radiological technologists are responsible for quality control in the diagnostic field in such countries. In terms of workforce and resources, we need to acknowledge that in many low to medium income countries, there are limitations on workforce manpower, as well as resources such as QC equipment, and we need to be flexible and have a multidisciplinary approach. We need to also recognize that in terms of titles, these do vary right across the world. There are many terms to describe the radiography profession. And in Asia and the US, it's radiological technologist, and in Europe, radiographer, Canada, medical radiation technologist, and in Australia, medical imaging technologist. But ISRT has agreed an appropriate definition, and that is radiographer, radiological technologist, to be used by all international organizations. Therefore, in the document, terms such as technician should be deleted or replaced with the term radiological technologist or radiographer. We need to be careful in our use of language. We need to be mindful with the narrative used in some places when phrases such as radiographers can also perform and medical physicists supervising radiographers are used. This could be seen as minimizing the radiographer's position, suggesting to the readers that radiographers are not to be trusted for such tasks. So instead of saying under supervision of a qualified medical physicist, say something like, if required, should be undertaken with the guidance and advice of a qualified medical physicist. We don't want to give the impression of a hierarchical structure. And certainly in the UK, radiographers regularly carry out IPM report a 91 level A test without supervision. Now, another general point in terms of there are challenges in meeting the different performance levels in optimization. A number of respondents indicate that reaching advanced level may be challenging due to the lack of resources and dose management tools. So resources are needed. Additionally, in terms of radionomics and artificial intelligence, we certainly welcome this development, but many facilities in the stages of development section may find it difficult to reach level A+ due to lack of resources. In terms of education and training of clinical staff, as a general point, we think that radiographers and radiologists have a key role in optimization of clinical users, especially in situations where no medical physicists exist. And this can be undertaken by skilled radiographers. Annex F, this is an excellent list that does not differ between the professions. And perhaps when referring to KSCs in the main document, this annex should be referenced when mentioning who does QC tasks. Now, in terms of possible additions, we would like some reference or greater emphasis to the training on use of accessories and other devices, such as contrast injectors, which may affect image acquisition and contribute to image quality. Thank you for listening to me. You can see my contact details if you wish to get in touch. Thank you ever so much.
Thank you very much, Stuart. I've had a sort of brief look through your sort of detailed replies, and sometimes we sort of write things off the cuff, and then we search and try and put them right as we go through the document. But it's easy to leave things which we should have addressed. And thank you for pointing all these things out. I think one of the problems that we have across the world is this inability to appoint medical physicists in countries where there is a lack of resources and a lack of personnel who can fulfill those roles. And perhaps we haven't addressed that fully. But we'll look at your comments, and then we'll think about that and what we do in places like Japan. I know other places in Southeast Asia and some places in Africa. Thank you. Look, Kimberly, do you want to proceed with the going through the other comments?
Sure. First, I wanted to ask if there are any comments amongst the panelists. If all the panelists for today could show their video so we could see them. Thanks, Stuart, and thanks for all your presentation comments, which reflect your written comments. So first, anybody have any comments from the panel members?
Yes, Kimberly, this is Guy Friger.
Yes.
I just want to react what the colleague just said right now about the needs to appoint medical physicists. But if you are in a country where resources are limited, if you have a choice of appointing medical doctors or medical physicists, there is no choice. They will appoint medical doctors. So I think that it is very important for us in this world of radiation protection specialists to think about that and to integrate the, I would say, the true risk of ionizing radiations in the context of a global health, quality, and safety.
Yeah, thank you. I think there was another question that I put in a kind of a quick answer to that relates to that point, that there are many engineers and that we may not have touched on that as much as some people may want, but there are many clinical engineers in hospitals and not enough medical physicists. We all know this. And so I know that Dr. Dina Husseini had mentioned it in her video, and it's more in the draft too. And there are efforts by the IAEA, I know, to promote in all countries the need for defining this expert. And it's interesting to us that it's not always that expert is not always defined in all countries, and how important they are for education and training and for the day-to-day workflow. And let me then move to a question by Gamal Akabani. It says, even though it may be a very sensitive question, training managers on how to purchase radiology equipment is challenging. Again, there is some information about that. And using the why can be helpful. There are many factors to consider, including budget, essential capabilities, and safety, and those are all important. In the US, FDA CDRH certifies equipment. However, the performance is secondary to approval. Will the ICRP be able to establish a minimum set of parameters for the acquisition of the equipment? And I would refer to the AAPM for some of the references, and I think we have some in the document. Does anyone else have a comment?
I think that's something more for the professional societies rather than ICRP.
There's another question, and maybe Mika, I don't know if you want to try to answer this, by Greg Stevens. How do you do optimization when manufacturers limit access to the underlying image? I am thinking specifically with fluoroscopy, where adaptive filtering gives a false level of signal to noise. I can't hear you. I don't know why.
Can you hear me now?
Yes.
Good. Yes. So it's a good question because it also ties to the use of quality assurance methods with fluoroscopy systems. So we should have an access to raw image data if requested from the manufacturer. And I know this can be a limitation in many cases. So what we typically do is to work closely with the vendor representation and the training specialist of the vendor. If that is not available, then it's much harder, I think, to come to a successful conclusion. So you need to team up with a vendor specialist in many cases in order to access the service level of the device and to acquire more deep technical parameters of the device.
This is a question that is kind of universal, but I'll raise it by Moulay Ali Nasiri. We have many guidelines and documents, no doubt. The problem is how to compel health facilities to implement the recommendations. Does anyone want to comment on that? I wish Dina were here. Oh, Stuart, do you have any comment?
Well, I think a lot depends on the country you live in. Certainly, in most European countries, there are strict rules and regulations with the various regulations in the UK, and they're well and truly well established. And you've got government bodies which are looking over your shoulder. So there is that legal system in a lot of countries in Europe which help to make sure that the standard of radiation protection is high. So I think where they don't exist, it's an upward struggle, I would imagine. But then it's up to the professional bodies to really bang on the table and ask for those resources. And hopefully the professional bodies can add a voice to that. I think we have a role in that, and we do have position statements as an organization which our members can present to their administrators, and then they can push it up. But I think everything has to happen at the local level as well.
Right. Agree with that. I don't. If Michael Kouya, are you on the? Are you available to address this question or comment about it? Because I think in Africa, it's, you know, every place is different. Every region is different. You've worked in AfroSafe. You're in Uganda.
Yes, can you come back again with a question, Vale?
Yes, the question is that it's, you know, that we have a lot of policies, but how do we make sure they're implemented? How do we get buy-in from the local facilities to actually use them?
I think the thing is key persons in that local facility, somebody who has a passion to implement that policy. And if we can get this person on board, and then train him and show him the vision and facilitate him and encourage that person, him or her, that seems the way to go in Africa until a critical mass of people who find this really useful on board. That has been my experience. There's always a need for a key person.
Right. So I've also found that having a champion who is, hi, Michael, good to see you. having a champion who has respect of their clinical colleagues.
May I intervene, Kimberly? This
Yes,
is Guy.
yes.
Yes, I think that more broadly, we have to address also the situation in low and medium income countries in LMICs. And I think in this area, we have to learn on how to use imaging without less radiographers, without less radiologists, and without less medical physicists. We have several options. I do not want to discuss them here today because it will be too long, but I think it's an important topic to be discussed.
Mm-hmm. I agree. I think there were two questions that touched on this for the role of the radiologist in this, because there are fewer of them. In fact, I read in Vancouver, there's an acute shortage where the images are not being read in a timely way, thousands and thousands of them. And, you know, there's a shortage of, you know, some radiologists in the US, and so it's everywhere. And so the question is, what's the minimum level of, you know, input from the radiologist for image quality and for protocols? And one way that people have sort of done this is to say, okay, you need one, like Michael was saying, one champion who wants to look at this image quality. It bothers them the most, to say, okay, what should the protocol be? Who's the, you know, expert in pediatrics? Who's the expert in body imaging, to kind of be that person on a small committee who can do it by email, do it by a monthly meeting, to say, okay, you know, let's get this right, and then track it. Or if there's questions, that person can be contacted, and it can be, you know, time minimized. But I think that's the answer. At least I'm gonna put that out there. And I've had conversations with Dina and Guy. You may have input as a radiologist on this, to say, yeah, there has to be some, because you have to make sure that people are in agreement and will be comfortable interpreting the images for that particular indication.
Yeah, but I want to say, Kimberly, sorry, I didn't put up my hand. But here in Africa, what we are doing is to train like radiographers and give them some basic skills for image interpretation, because really we are very few radiologists. And these are proved to be very handy, especially for plain films. And they can also give a comment on the quality of the image. And it's a feedback, because since they're doing the images themselves, they see the rationale for good quality images when they find problems with interpreting images which are not of good quality. Over to you.
Yeah, I know.
If I may have a question to Michael, what would be the better way? Would be to develop what we say, or to develop implementation of artificial intelligence, which allowed, you know, a quite reliable interpretation, for example, for plain X-rays. This is now already widely demonstrated.
Gee, we are working, actually in Uganda, we are working on both fronts. We are developing artificial intelligence in tuberculosis and in other areas. There's a research in those areas. And later we hope we shall translate it, but there has to be a human face. Somebody has to be responsible for something, and so I think the two are not mutually exclusive. I think the two should be taken together. That's my feeling, but it's much easier for us right now and much more practical to scale up training of radiologists, but also to bring on board radiographers and equip them with extra skills for film interpretation, and also for vetting quality of images.
I know Stuart also mentioned that. I'm in a tough position because the ICRP and the IAEA and the basic safety standards, you know, are, you know, saying scope of practice says, you know, radiographers don't interpret, but I understand that that's just simply, you know, a resource limitation in many countries. So I get that. And I don't know of another solution other than AI. And what AI has been focused on in at least in the US has been exactly what Guy, you have brought up, which is screening, so to speak. It's to get past the FDA requirements. The AI has been trying to screen the imaging so that it finds the key problem. It either finds the tuberculosis or it finds the nodules and says, hey, these are the things that you need to look at. These are the things you can dismiss. It also can do prediction. And for like hemorrhage on a head CT, and that really needs to go to the top of your list of interpretations. Those have been approved for some time. And so that's what I think is going to be the future. It's kind of interesting to me that these have not been picked up by many groups in the US. Very few groups have any AI in their workflow. So it's been slower than I expected for picking up. And things like reading a chest x-ray for pneumonia in children. Stanford has really led in this, but there have been very few practices that use it. Let's see. There are a number of other comments. I can't quite read. It's Mangani asks in terms of careful use of language in a multidisciplinary team or a specialist like surgeons or orthopedics do not understand radiation safety as well as the radiographers, who are better to advise about unnecessary high number of fluoroscopic images which increase the dose. So I suspect that's in the operating room, and we certainly have the same problem here. So I don't know if Mika or Guy or who wants to answer that? Anybody? Stuart?
Could you rephrase the question, please?
Well, the situation is perhaps in the operating room or in the C-arm use, where in the emergency room where the orthopedic surgeon is using the C-arm and has the radiographer there, and they're using too many or unnecessarily high number of fluoroscopic images. And they don't understand radiological protection or optimization.
I think that boils down to maybe the role of the radiation protection supervisor and the infrastructure that's there in that particular facility. Whether there's a radiation protection committee which tries to infiltrate to all the various aspects of that hospital or health facility. But certainly anybody who's using like a physician or orthopedic surgeon, they need some basic training. So I'm hoping that they will receive some, particularly if they demand to use the foot switch. And of course, this is the role of DRLs as well in the theatre, because you can have a situation where the radiographer can say, well, you've reached so many minutes, you'll have to stop, or point out to them and report that situation. Maybe that person needs training, but I think there should be some sort of infrastructure to stop that from happening.
Right. I think it is resource dependent. Having a radiation safety officer can also help, who often heads the committee and brings it to the attention of, the different groups. Oh, David.
I was going to say just about exactly what Stuart said, that, yeah. And in fact, it is really relevant to our document, because the questioner is asking a question that sounds like it's at level D, it's at the pre-optimization level. There is very limited infrastructure. And as Stuart says, a radiation protection committee that involves senior management in the institution is really what you need in that circumstance. So, you know, a radiation lead who can then promulgate policy that can then be imposed and by a supervisor on the ground. It's, you know, it's exactly where we think a lot of places are and need to develop some infrastructure to get them on the road to optimization, because that's obviously miles away from any type of optimization at all. Somebody randomly putting their foot on the pedal without really understanding what it's about. So yes, I agree with Stuart.
Can I say something also, that a multidisciplinary approach does not remove individual responsibility or professional responsibility, and that in this case, for instance, in the interventional room, the radiologist and the radiographer are the ones who really best understand radiation and its effects, and so they're the vanguard. So one of them has really got to lead out and say, yes, I think we have overshot this. I think let's do this. So I think that allocation of roles and duties is really important, even though we are having a multidisciplinary approach.
You're absolutely right, and we make that clear in the education and training chapter. It is up to us as an individual to ensure that we get the education and training we need.
One point, Kimberly, I would like to address now is what should be our strategy with other specialties which are using X-rays and which are not trained for that, right. And mainly cardiologists, orthopedists, and gastroenterologists, because until now, as far as I know, there is not, I would say, a structured strategy for that. And I think it would be the right moment for doing that, and to see how at the European level, maybe it would be more easy to have some ideas on how to proceed. But around the world, it's not easy to say how to address this issue.
Right. I know we have to close, and I'm just going to say that we've provided you know, a publication on education and training in 2009, which was for everybody, and you know, for all involved. The IAEA is working on an education and training document. The National Academy of Science in the US is working on a training, a way to provide training for all undergraduates, you know, medical students, dental students. So this is a hot topic. So I'll leave it at that.
I agree that undergraduation, it's, I think, the right target. But
it goes beyond that. I'm sorry.
Yeah,
it starts there. It goes beyond that. And we make that clear in this document too.
It's how to implement that as the professional activities. This is more difficult.
Yeah. Colin?
Yeah, well, I think we're I mean, we know that there are lots of problems that have to be addressed, whether it's different clinicians that we haven't, we need to specify a little bit more on, but I think that is covered in our training document. But I think the biggest one is the one we've sort of been discussing around today, where in countries in Africa and some other parts of the world, there aren't all of the specialties that we have said are required in our report, and because of resources, that's not going to be possible. So we need to maybe have some sort of a think about addressing what the fallback position is. But anyway, we've come to the end of our session, and thank you all for contributing. And we're open, as I said, for comments on our document until the end of Friday. So I would urge you, all those who have things to say, to submit your comments, and so that we can consider them in detail. And then we're back tomorrow at the same time to continue the discussion of the other parts of our document. and hope to see you there and try to thrash out some of these problems. Thank you.
Thank you. Bye-bye.
Bye. Cheers. Bye.
Thank you. Bye-bye.
Very much. Goodbye.